Thank you, dignitaries. Now,
Sir.
Just hold it. Sir, and now I request you to hand over the next award also. This award is. Thank you, sir.
சார் படம் எடுத்துகிட்டு உட்காந்துறீங்களா? ஓகே ஃபைன்.
சார் சார்
Thank Agarwal. Why? On two spectra. We have heard about community dentistry, right? We talk about community medicine, right? But there's something called community ophthalmology. So I just want to rapidly flash back to the year 1972-73, when Kalaignar was the Chief Minister of State. He introduced a program called Kannoli Thittam. Kannoli Thittam means eye vision scheme. So basically, the scheme stemmed from the various inputs from various ophthalmologists, especially Agarwal sir. Agarwal Sr was also contributory to the project. What project it is? They did a survey. What survey they did is cataract was there. There were not much of solutions for cataract at one end, and there were also huge incidents of vitamin A induced blindness, night blindness. So whenever a patient gets cataract, especially for people for low socioeconomic strata or people working in a very daycare laborers, their work efficiency stops when they develop initial cataract. Imagine year 1970-73, at age of 60, if they develop cataract, they can't go to work. So when they are not able to do work, their income gets affected. Not only their income, their family income. So their livelihood is gone. So the study was made. What is the impact of cataract on the life expectancy of the people? Because of proper access to health was not there, because of proper livelihood was not there. There was a 10 years decline. So there was 10 years decline for a patient age of cataract. So what to do? So Kalaignar announced this system in the year 1972, where first time in the world, with the target of treating 1 lakh cataract operation, they started something called community hospitals. Community mobile hospitals. One of the think tank was Sr Agarwal into that scheme. Many renowned ophthalmologists were into the system to contribute both in public as well as private. Here, our Sr Agarwal sir was one of the think tanks here. What will they do? They selected districts like Coimbatore, Madurai and Thanjavur. A camp will go in the Taluk area in Kalyana Mandapams, in marriage halls, where they set up aesthetic theatre formats. 20 surgeons will come at a point of time, and they start doing cataract operations. Around 2,000 cataract operations per day. Imagine within 1 year, the project completed 2 lakh cataract operations. Within 1 year. And in the year 73, V.V. Giri, the then president, came and congratulated the efforts of community ophthalmology of then the government. Then Seorsborg was a Western WHO eye expert. He said that this type of mass cataract program was the best in the world. That was the acknowledgement was given thanks to the contribution of Dr. Kalaignar, thanks to the contribution of Agarwal sir and various other renowned eye experts in community ophthalmology. On that basis, I came and stand here. In 2001, I started a similar Kannoli scheme in my constituency with Agarwal sir. So the legacy continues. So So we have completed around 300 cataract operations. We have screened around 3,500 so far. So we have conducted around 10 camps so far. All complicated cataract surgeries have been done by our Kalpavriksha CME scheme by Agarwals Eye Hospital. So the legacy of community ophthalmology continues and will continue to serve the needy people. At the same time, we'll update our knowledge in various scientific endeavors and getting exposed to various innovations coming up worldwide far. Thanks a lot. The topics being covered, the efforts being made into. See, in case of any medical institute or any medical education, first is patient care. Yes, that is vital. So predominantly 90% and 99% of the many of the private setups, private service providers are limited only to patient care. Now, Agarwal has made one more surmountable strides in research, teaching in the form of continuing education program, which is very vital for any institute to expand. That is across mutual transfer of knowledge, mutual transfer of best practices in the respective specialties is the core for any institute or to deliver this type of services, which is very vital. Running an institute serves that particular segment of population, yes, accepted. But doing an education program, they are expanding the branches. So when you learn your best practices here, and you're going to start up your own respective units elsewhere or in future, so you'll be taking up the very vital discussions in various topics which has been discussed today. I come here on two bases. One as a people's representative and second as a treating physician. I'll do the latter first. So I have an active practice still going on. What is it? Physicians, ophthalmologists think, because we are into the world of metabolic diseases, especially in southern part of India, we all carry a diabetic gene with us. We have started seeing hypertension and diabetes at 11th standard and 12th standard. The recent survey, school survey which I did in my constituency in urban slums, irrespective of the social strata, systemic hypertension was around 11%. Diabetes is around 13 to 14%. Alarming. Imagine at 12th standard, a kid, a boy, a girl developing hypertension, diabetes. In a matter of 10 to 15 years, their end organs are going to be affected. So at the age of 30, 35, they'll end up with stroke, heart disease and dialysis. Now all our intensive cares, when we started our practice was geriatric. Now it's young population in our intensive care. Young women are in intensive care. No wonder we have a metabolic liver diseases going up with a very huge incidences. Why should I address these to an ophthalmologist? Because you are the eye opener, right? Your detection of diabetic retinopathy, your detection of hypertensive retinopathy warns us, as well as it also gets oriented for a physician to get exposed. My humble request to Ashwin is to conduct a CME program for practicing physicians to how to look about the fundus, how to detect hypertensive retinopathy at early stage, how to detect diabetic retinopathy at early stage. That type of CME program for actively practicing physicians is very vital because it gives us a direct vasculature assessment. For a coronary angiogram, I have to do an invasive procedure, right? For an ultrasound, I have to do a Doppler, renal Doppler to detect. For a carotid, I have to do a carotid Doppler or an MR angio. But here, I have got a simple clinical examination tool to directly visualize the blood vessels in part. So your role is very significant for us. Your knowledge on this metabolic diseases and its pattern is very vital for us because you are the ones who visualize the vasculature indirect and warn a physician or warn the patient about the control of metabolic parameters on that one segment. Second, see, an eye opener means it's an external manifestation of systemic diseases. So I will humbly request our ophthalmologists to get oriented on the systemic patterns or ophthalmic presentation of systemic diseases. Because a choroid TB, a PO for evaluation, right? My experience is this: a choroid tubercle will give a picture, and a nodule in the iris for a PO evaluation will open into tuberculosis. So there are many diseases which are systemic manifested diseases which will be reflected in ophthalmology. So your orientation of systemic diseases is very vital. So again, I request Ashwin to have a collaborative CME on various systemic diseases reflecting in ophthalmology. And these are my inputs. My days are there in toxicology ward in Madras Medical College, which I did my UG and PG, where we able to detect various types of poisons by seeing the pupil. So we had loads and loads of poison cases coming to our referral center to Government General Hospital. Just by visual pupil examination, we were able to identify what types of poison the patient has ingested, whether it consists of mydriasis poisoning or meiosis poisoning, depending upon just throwing a torchlight onto the patient's pupil. So our field is expanding. See, the advantage of bigger institute and learning in a bigger institute is fine. But at one point of time, we should understand we are all entrepreneurs when we village talk. Just like any small entrepreneurs or small startup, an ophthalmologist goes back to his hometown or goes back to his area of practice. So he has to invest huge on instrumentation. It's very simple for a physician. A BP apparatus, a box, and my clinic is started, that's right. But imagine for an ophthalmologist, the investment is huge in terms of infrastructure. So some education about ophthalm economics have to be delivered to the postgraduate students, because we are very bad in money handling, right? About the investment, and how to start about investment, where you get cost-effective machines, where you get cost-effective gadgets. So that type of orientation transfer, Agarwal has a huge experience on the economics of ophthalmology, on the business of ophthalmology. I mean, business means I don't want to put out what do you say, a very candescent or industry-oriented approach. Here I say the business of ophthalmology is to educate our young entrepreneurs who are going to start up the practice, because Agarwal is in legacy, is one of the first primary institutions that started from very, very humble backgrounds in a small clinic. Now they are expanded to 3 generations into an institute, into a teaching facility. So you have surmountable experience for knowledge for transfer for our young ophthalmologists to educate them on the economics of ophthalmology, how to start up a small clinic in a very baseline economic conditions, in a rural background or in a semi-urban background, which should be vital for you. So these are the areas we have to educate our young ophthalmologists.